Hey everyone, welcome back to another episode of the Brawn Body Health and Fitness Podcast. I'm so excited that you're joining us today. Today I'm joined by Dr. Jonathon Gardner, and John and I are going to be discussing physical therapy considerations in basketball players. This works out really well since John is a performance physical therapist working with the Charlotte Hornets NBA team, so he has a ton of knowledge and experience and insight in working with high-level basketball players. I know you're going to love this episode, and make sure to check out John on Instagram for more. John, welcome to the podcast. I'm super excited to have you on today, man. Thanks for your time.
Yeah, man, thought we could get this going, and we were trying for a couple of weeks. So I appreciate you working with our crazy schedules.
Yeah, I can imagine. So, for people who, aren't familiar with you and, what your crazy schedule would entail working for the Charlotte Hornets, would you mind filling them in a little bit about who you are and what you do?
Name's Jonathon Gardner. Go by John often. Just don't tell my mom that. I'm a sports physical therapist, strength and conditioning specialist. I was previously in the private sector world up in like the DC, Baltimore area with a couple different companies coming out of school. I was up there for about 4 or 5 years, and then always knew I kind of wanted to hop into the professional sports world or whatever. So, just constant networking, honing of skills, all that good stuff, meeting the right people, and managed to, receive the opportunity to work for the Hornets. So this is my first year with them. And it's been everything I can think of. So again, I've been here this year and first season, and it's got its pluses and minuses compared to private practice. But overall, I mean, I'm just loving it, thrilled with the opportunity and career
Yeah.
change.
Yeah, that's awesome. And that's an incredible opportunity to be around, the best of the best in the sport of basketball, because I believe you are a very basketball minded individual. I think at one point you even called yourself the dunk doc or something like that.
Oh God, I think I never termed the nickname, so other people did that back in the day when I could actually get up and dunk a little bit. But no, I played basketball in college. I had my own share of injuries, nicks, bruises, and stuff like that. So again, went the PT route, enjoyed it, learned very early on that I was probably not going to be one of the best in the pros. So I figured I'd find another way to get there. And that's kind of what drew me into this realm. And again, like even in the private practice, particularly when I was at True Sports there in Maryland, kind of tried to hone in on the basketball population just because I felt like it was a little bit underserved in some of those markets compared to obviously the booming lacrosse and stuff like that that's up in the state. So yeah, I've been chasing basketball rehab since I came out of school, and managed to find myself in the realm of working with the best of the best. So it's been fun.
Yeah, definitely. Now, I know you can't necessarily give specifics on certain players or anything like that, but in general, what would you say you typically see on the day to day as a PT who works with high level basketball players? Is there any kind of specific injury you see a lot of, or any kind of common aches and pains? What are you typically seeing on a day to day, John?
Right. So I'd say the majority of the time, like you're doing what we would call like performance care type stuff. So it's less true rehab type stuff. Like obviously you've got your post ops and your true contact injuries and stuff like that you're going through real rehab process. But more often than not, day to day basis, it's more maintenance care type stuff. Like you're checking every joint from toes up to the hips. Um, and kind of going through that checklist with these guys, looking for any change in like muscle tone, any pinching in the hips or groin or whatever the case may be. In terms of like most common injuries that you're going to find basketball wise, if you're looking at knees and ankles, I know there's been a ton of ankle sprains for some high profile players throughout the league this year. Um, and again, like the majority of those are contacts, and it's so much they're avoidable. It's just the nature of having these guys flying through the air and landing on somebody's foot. So I think that's probably the most prominent thing you're going to see with these guys are contact ankles, and then you'll see general overuse injuries for knees, whether that's tendinopathy type stuff, whether it's chondral lesions and osteochondral defects or whatever the case may be there, and then your constant like niggles, we'll call them, like just tweaks through calves, hamstrings, groins, quads, hip flexors, etc. But I mean, more often than not, when you're looking at injury reports, the majority of these guys are having some sort of lower extremity type thing. But I'd say definitely ankles and knees are typically what you're going to see. We don't get a whole lot of the, I think it's just the nature of the sport. You're not seeing a whole lot of ACL stuff, right? But that stuff's pretty few and far between. And again, those are normally freak contact injury type things, but more often than not, those ankle sprains and then just chronic overuse stuff for the knees.
Now, does that vary at all if you look at female basketball players, or would you say it's relatively the same across the genders?
I mean, there's always kind of been that trend of you'll see more of the ACL type injury across your female basketball players for sure. It's certainly what I saw more of in that private practice setting. Was definitely more post-op basketball females as opposed to males. The males were more tendinopathy, occasionally meniscus type stuff, but the ACLs were typically female.
A little bit ago, you had mentioned too about how you kind of have to screen a lot of these guys from head to toe, or really from hip to, the foot there on a regular basis there. So walk me through what some of that stuff might look like. Are you a special test guy? Are you just looking for changes compared to the previous day? And, how do you streamline that process? Because I'd imagine you've got quite a few people to look at in a short amount of time. So how are you able to kind of get the quality info that you need and get out in a, decent time, I'll say?
Right. So, I mean, the blessing of being in this setting is, I mean, I see these guys every single day, right? So again, like you've got a good idea of like previous injury history, you've got a good idea of like what their load was from the day before, whether that's practice, game, off day, what they're doing with strength and conditioning guys, etc. So I think just my staff's ability to effectively communicate that, even up to like the basketball skills and coaches, having them and knowing those sort of metrics going into the day helps you kind of streamline. Like we do wellness questionnaires and stuff like that, and we know that if they've played a certain number of minutes the day before, they're more than likely going to select the soreness level of XYZ kind of thing. So you know to hone in on those guys who are higher load guys, for sure. And then again, a lot of it is talking to these guys and communicating with them about what they feel and stuff like that. I think a lot of people assume that like I'm running the show kind of thing, when in actuality it's very athlete driven, at least with our kind of stuff. Like these guys, they may not be able to articulate it the way you and I can, just in terms of talking like biomechanics or anatomy or whatever the case may be. But these guys are so, I mean, they're the highest level athletes you could possibly get. Like they are very in tune with their bodies. So again, like just taking them through a general movement prep screening that involves like a squat, a lunge pattern, a toe touch, etc. And again, like they can tell you very quickly, like, like my hip feels a little funny today, or like my calf feels tighter as I'm sitting into this squat or whatever the case may be. So it's running them through their general movement prep type stuff, and then just doing general range of motion testing on the table kind of thing. And again, you can hone in on guys' specific complaints that they've had throughout the year and stuff like that.
Yeah, that's awesome. And, as you mentioned, you certainly have the benefit of seeing them regularly. You also alluded to the collaboration between strength and conditioning and PT. And as we talked before, off the podcast, I think that's really the future of good sports and performance-based physical therapy, is having everyone under the same roof and working collaboratively together to improve an athlete's situation. And I also love how you mentioned the importance of what we would call, the subjective report. So what the patient, what the person you're working with, your client, whoever, what they're telling you, because that really, I think that makes up easily 80% of an examination of what you're going to do from there. Is you have to listen to what they're telling you, and you have to kind of ask yourself, does what they're saying match what I see? And I think that's something that, when we look at like schooling and that sort of thing, a lot of schools, at least in my own experience, they kind of, I say, miss the importance of that, of listening to someone and hearing about what they're feeling and what's going on. They kind of push you into a special test realm and what you see and what you feel, when in reality, we kind of work for our patients. If we don't have people to treat, then, we're not going to be treating anyone. So we kind of have to listen to them and cater everything we do to what they need specifically, or what they feel they need.
Exactly. And again, like some of these guys, I've had other people ask me, like, what do you do? What like cool, like modalities and stuff do you have? And again, like we've got cold tub, hot tub, sauna, cupping, scraping, dry needling, E-stim stuff, bone stimulators, anything you can think of, we've got it, right? So, and again, like some of these guys, whether I think that's the perfect intervention for the day or not, again, if they come in and they're like, hey, my calf's really tight, can we needle it today? Again, off the bat, you know that player thinks that intervention is going to help them. So again, like people call it placebo, whatever you want to call it, right? Like there's going to be some sort of positive change just because they're expecting it, right? It's also allowing them to have a piece in the process of their rehab or just their general maintenance care and stuff like that. As opposed to me be like, I don't think we should needle today. I think we should scrape, or I think we should just stretch, or I think we should just go do seated calf raises, or whatever the case may be, right? Like I think letting these guys have a seat at the table in terms of how their rehab and maintenance care throughout the season goes, it gets you buy-in and stuff like that. But again, like going back to what I said initially, these guys are super in tune with their bodies. So again, if they think this intervention's given them a reason to pass, then they're probably going to go with it.
Now, I'm sure out of all those modalities you mentioned, I'm sure the first one you usually reach for is the ultrasound, right?
Nah, we don't even have to think of that. So that's in the closet somewhere.
Yeah, we don't even have one. We left that 30, 40 years in the past. So you mentioned before too, you see a lot of tendinopathy type of issues, whether it be patellar tendinopathy, Achilles tendinopathy, whatever. How do you like to go about treating those and managing those in basketball players?
Right. So I think the biggest thing is it's always it's a load management issue. And I know that word gets tossed around, especially in the NBA a lot. But again, it's for whatever reason, that tendon complex, it's become overloaded by too much work or an unexpected spike in load kind of thing. So I think the first thing that we're typically doing is you got to get that stuff to calm down. So again, it's removing that load and going after some lower hanging fruit, just in terms of ways to properly load that structure without, for lack of a better word, pissing it off, kind of thing. So I think early on, isometric work is an easy, like ground level kind of thing. Like it's low hanging fruit. I know I'm getting targeted load through these tissues, whether it's a calf for the Achilles, a quad for the knee, or whatever the case may be. So I think that's typically where I'm going first. And again, like at least in my level, these guys are high level movers, freak athletes and stuff like that. So you got to be really careful to not let them compensate their ways out of loading that tissue, because again, you're going to get a huge nervous system response to avoid loading that tissue. And again, like these guys have unbelievable strength and elasticity in other places that they can use to kind of hide that deficit. So if we're talking about quad or patellar tendinopathy kind of thing, they just won't load their quad. They'll load hip. Again, they've got super long femurs, so they're probably more hingy anyway, as opposed to squatty. So they're not going to get a whole lot of load through that knee extensor complex in general. So it's seeing that and it's being able to take them out and provide enough constraints to truly get load through that knee extensor mechanism, as opposed to sitting there and be like, okay, like we're going to squat today, and you think you're getting a ton of load to the quad, and in actuality, they're shifting everything away from it. They're loading all posterior chain, and you're wondering why it's not getting better or tolerating load kind of thing. So again, for me, sit somebody in a knee extension machine and just have them sit there and push. They can't use their glute, they can't use their hamstring, they can't use their low back, right? They can only use quad. So I think that's why going to some of these like single joint, isolated isometric type things are so beneficial early on, just to get load to the tissue that you want.
Yeah, I completely agree with you there. And, I think iso loading is certainly a phenomenal intervention, especially early on in the rehab process, because there's a fair amount of research coming out that shows it helps to modulate pain. So it's like, if I can get the same effect of a modality through exercise, then I'm already bought in. And, the more we look at things from a research standpoint, the more it seems to point to total time under tension being important for tendon loading. It's not the eccentric only phase or anything like that.
Right.
It's
Right.
the total time. So if I can push someone into a 30, 60, even 90-second isometric hold and get the loading that I want out of it, and I'm killing their pain, then I'm happy with that. And I love how you brought up the leg extension machine ISO hold. I've even used just a ball at a wall and having
Yep.
people kick into that if that's not available, and then progressing it into different lunge variations once you're ready to go back to standing. And
Sure.
even getting multi-planar with it is doing like a lateral lunge where you kind of sink into that knee over toe position and hold there and just kind of break out of the monotony of forward and backwards sometimes.
Yeah. Yeah.
Now, you also mentioned about the shifting into a posterior hip kind of approach there to avoid a patellar tendon load as like a compensation.
Sure.
Have you ever seen any kind of tendinopathy type stuff up in the hip at all, like a glute or hamstring or that sort of thing?
I mean, you'll see some glute tendon irritation type stuff. But again, some of it's just a general lack of mobility. These guys are occasionally wound pretty tight, and again, like that's probably what gives them their inherent spring and explosiveness and stuff like that. I wouldn't say we see a ton of it. You'll see more irritation. Like again, it's that quick change in load profile kind of thing. So again, like if they've had time off over the summer and we're coming in preseason and all of a sudden we're adding in like some of this heavier load through like lateral hip or posterior chain type stuff, you'll occasionally see a little flare up. But again, I think it's been a blessing having the strength staff that we do, just being able to progressively load these guys as opposed to just coming back and going 100 miles an hour has avoided us dealing with a whole lot of that like glute tendinopathy type stuff that you'll occasionally see. So don't see it too much.
Gotcha. Yeah, that's great. And, is there anything that you found from your experience thus far to help mitigate the return to sport or transition in sport sort of thing, like you just outlined? So you mentioned about, having a slow ramp up instead of just jumping
Sure.
right into things. Is there anything that you've found in your experience thus far that's kind of helped that outside of just kind of collaborating with the strength coaches on the
Sure. So I
progression?
mean, we have sports science department here as well, and again, like Dan Taylor's our guy for that. He's been incredible kind of stuff. And again, like that's going. I mean, wellness questionnaire is a daily thing. We do saliva testing to look at inflammatory markers and cortisol response kind of stuff to load and travel and all that kind of stuff. We do force plate jumps, and there's a ton of other force plate tests that we'll do. So you'll do, I mean, we call it a sway test. So again, your ankle sprain. First thing that we're going to check is their sway test and force plate just to see what single leg stability looks like. And again, once that kind of evens out and gets into the proper percentile range of the opposite non-involved leg, then you progress that to a double leg drop into a single leg land and hold, and then typically you're progressing them back into a kind of jump kind of stuff. In terms of the on-court stuff, again, just the coaching staff that we have here they are fantastic listeners, and again, the majority of these guys have played as well, so they have a good idea of what a normal progression would look like and stuff like that. So then they're very receptive to us being like, okay, this guy's first day back on the floor doing skill work post ankle sprain. We're gonna limit time on feet to this. We're gonna limit number of jumps to this, and we're gonna keep him moving just in a sagittal point, that kind of thing. So just forward backwards, whatever the case may be. And then we'll look at Connexon data, like GPS type stuff. That will look at number of XLs, decels, jumps, distance covered, time on feet, number of exertions, and stuff like that in terms of low intensity to high intensity. And again, you're trying to reverse engineer that data from a guy's peak game data, like the peak speed they'll hit, the peak number of acceleration, decelerations they'll hit, and you're working backwards. So you're starting at like 25% load. That goes well, you bump them to 50. That works well, you're bumping them to 75. And again, bringing it holistically, you've got the player giving you their subjective report every single day. You're getting their wellness stuff. You've got the metrics from dynamometers, force plates, and the Connexon data. and you're just kind of bringing that all full circle and putting it together in terms of like that return to play process kind of thing.
Yeah, definitely. That's a great way to approach it. Say you're someone like me who's in the private sector, and
Sure.
unfortunately, I have access to a lot of cool stuff, but I don't have everything that you just outlined.
Sure.
I can't get lab work, and I can't get a lot of the force plate type stuff data wise on these athletes. So, how would you approach something similar from a private sector standpoint? Maybe if you don't have access to all of that.
Sure. So I think video capture type stuff with some of these more sport specific movement kind of things. Um, Again, like even in your setting, like I think that subjective report from a patient is huge, right? Like I typically tell guys, and even back when I was in private practice as well, like we're looking for like that 24-hour pain response kind of thing, right? Like if it blows up and it gets agitated, I mean, you're talking whether it's an ACL repair, a glute tendinopathy, posterior tib tendinopathy, ankle sprain, whatever the case may be, right? If they're coming in the next day or they're waking up the next day blown up, then we did too much. If they're waking up the next day minorly sore through some of those targeted areas that we kind of loaded, then we're probably trending in the right direction kind of thing. So I think taking that 24-hour pain response has always been key for me. And then going through their subjective report. And I know hop testing is a hot topic now kind of thing. Like people hate it, people love it, whatever the case may be. Like I think as long as you are measuring something and have a rationale behind why you're measuring it, why you're using it, and you're seeing that your progressive rehab is improving some of these metrics that you're looking for, then you're typically in the right spot as long as it's coinciding with the patient, the athlete telling you that, like, yeah, like I'm feeling better, I'm feeling like I can do more, etc. And again, just giving them, like, if you got a basketball player and they're coming off of whatever the injury may be, it's figuring out, okay, what would a normal day look like for you? Like, let's say we weren't hurt, what would you normally be doing? Okay, well, let's cut that in half. So again, if they would go work out for an hour, it's like we're going to go do 30 minutes of shooting, come back to me the next day, let me know how you feel, kind of thing. And again, you're monitoring swelling, um, strength, hop testing, whatever the case may be. You're just making sure that everything's trending in the right direction.
I've never even thought about just taking a picture of their whole day and kind of mitigating load through that. In the past, I've worked with golfers and we just kind of reset everything down to wedges and then progress up. I've worked with
Sure.
cross athletes where we just kind of, mitigate how many shots they're taking a day, or,
Right.
with baseball, it's easy to kind of do like a pitch count or a swing count. I've never thought about doing it like you just outlined in basketball and saying like, look, let's just look at the time that you're doing it. Like if you're on the court for an hour, let's just reduce that and see what happens. Because as you mentioned before, a lot of the common aches, pains, and injuries you see are overuse and load management related. So if we reduce the load temporarily, but you still get to play your sport, that's a lot better than not playing the sport at all and having to sit out for weeks or longer.
Right. And I think that's the biggest thing, at least in the league here, right? Is the end goal is these guys playing, right? I know basketball players in particular get a bad rap for not wanting to lift and stuff like that. But at the end of the day, like I would rather that guy get targeted load through tissues via skill work kind of stuff as his main portion of his rehab over coming in and doing an hour session of PT or an hour session of strength. Because again, the end goal is to be on the court playing and participating and stuff like that. So I think it's not belittling what we do, but again, like keeping in mind that there is an end goal there to be on the court. It's not to be on the treatment table or the leg extension machine or whatever the case may be, right? So it's making sure to prioritize accordingly. And basketball is the bigger piece of the pie kind of stuff, and it's using our knowledge and expertise to kind of work around that and provide the stimulus or the recovery or whatever the case may be that these guys need in conjunction with the sport.
Exactly. Yeah. I mean, regardless of what level you're at, high school, college, NBA, the sport is the investment, right? So you've put some kind of time, effort, energy, finances, whatever, into the sport that you play, in this case, basketball. So our role should be to protect your investment and keep you in there as long as possible. And, I even tell a lot of my patients who are post-op ACL, we could keep you in PT forever and probably reduce the risk of this happening for, quite a long time.
Yeah.
But if we do that, then that kind of defeats the purpose. The whole goal is to get you out of here and get you back to doing the things that you want to do day in and day out as you were before, or better than you were before. So I think that's important conversation to have of, the importance of what you're doing and why you're doing what you're doing, because
Right.
it would be great if I could work with every athlete and try and make them a great lifter. I would love if I could make athletes
Sure.
work until they front squat 315, but that's not what they want. That's not what they need. And that's not why they're here. I love that conversation. Switching gears a little bit here, John, we missed the ankle when we were talking before. Walk me through
Sure.
some of those low and high ankle sprains that you see, and walk me through some of the Achilles tendinopathy type management that you have too.
Sure. So, I mean, you're not typically going to get a whole lot of high ankle stuff. It's typically your lateral ankle sprain. And again, more often than not, these are contact injuries. Like, these are guys landing on people's feet, right? Again, there's some big feet rolling around through here too. So again, it's hard to avoid sometimes. So again, we're dealing with mostly, I'd say the majority of basketball players are suffering lateral ankle sprains and stuff like that. I mean, it's the same sort of thing, right? Like, we're starting off with swelling management and stuff like that. And again, like, I think that's been one of the bigger perks of getting into this job, is I now get to work alongside athletic trainers on a daily basis, and that's their wheelhouse. So again, like, swelling management, edema management via dry needling, compression, icing, contrast stuff, wraps, etc. Like, having the chance to learn some of that stuff's been pretty cool. Again, we've got an incredible staff of athletic trainers that have been able to show me the ropes with that kind of stuff. Because again, like, I think, icing's become another hot topic in the rehab world. Like, oh, we shouldn't ice, yada yada. Well, these guys feel way better when they ice, so probably ice, right? That shouldn't be your end all be all. But again, it's been huge to kind of come full circle on that, coming from a clinic that, again, we touted that we didn't do modalities, to again knowing the proper time and place for when to use that stuff. So acute wise, again, you're just managing swelling and stuff like that, and you're trying to restore joint motion ASAP, right? So again, whether that's manual stuff, whether that's getting these guys on their feet and moving them through different ranges of motion, making sure that we're maintaining dorsiflexion and that sort of stuff is key early on. And then again, like, we have the luxury of having a dynamo, right? So I can use that kind of stuff to get inversion, eversion, dorsiflexion, strength numbers kind of stuff. And again, comparing it to the opposite side. Again, we're starting same sort of thing. We're getting load through those tissues, typically via isometric type stuff, like your classic four-way ankle. But again, it's done with the intent of moving these metrics so that we can get them back up on their feet and again start doing single balance and stuff like that.
Yeah, I love that. And I completely echo your point on the ice, John, is even in the post-op patients, right? Like, some of the best surgeons in the country are telling their patients, look, you got to ice, because if you try and load and move a knee that's swollen, or in this case, an ankle that's swollen and irritated, it's not going to feel good. So if we do something to help reduce the swelling, it's probably going to feel better and move better. And like you mentioned, ice is a hot topic. Compression and elevation is also, hot topics. Like, oh, well, it doesn't do anything. And it's like, well, it controls swelling. And if we control swelling, that does quite a bit for us, actually.
Yes.
So I think that's huge there. I also love how you kind of brought in the AT side of things as well, because I think that, a lot of times as practitioners, we tend to get very narrow-minded and think that we have to do everything ourselves, when in reality, it takes a village. As you've kind of mentioned throughout this, it takes the coaches, the strength coaches, the ATs, the PTs, everyone coming together in order to get someone better. And that's the best results. So, say you're like me and you're in the private practice realm, it might not hurt to get consent from the patient to email their coaches or their strength coaches or their AT at school or whatever that way, and try and just kind of bridge that gap and collaborate a little bit more, because that's going to give best outcome from the athlete. And oh, by the way, if their AT is managing swelling and edema for you, then you could probably do a little bit more in PT with them. And, another regard there. I also love how you brought up even the importance of something like a four-way ankle exercise. I think in general, sports PT, and basketball certainly falls into this, has become this thing that people feel has to be glamorized by cool exercises that show up on Instagram, when in reality, sometimes it's the basic things done really well that get them where they need to be. Now, don't get me wrong, I'm guilty of it myself. I'll post some cool exercises on Instagram every now and then, but how often do we see a post-op ACL patient posting their quad sets and their straight leg raises, or a high ankle sprain patient who's posting their initial ankle four-way or ankle pumps or something like that. Like, that's the stuff that I think often gets overlooked and yet has such an essential part of the rehab process. And I think, if that's missed, you're not going to get them back to all the cool, fancy stuff. Like, how are you going to get someone back to jumping or dunking a basketball if they can't even control ankle dorsiflexion, plantar flexion, and open chain?
Exactly. And again, like, I think it even goes back to what we were talking about with tendinopathy, like the same sort of thing. Like, you got to make sure that you're getting load through tissue that you're targeting, right? And again, like, that more often than not is going to start off with single joint, isolated movement. It's not going to be this crazy banded, twisted around this way, controlling trunk and stuff like that. Because again, your nervous system's going to avoid loading that stuff because it hurts, or whatever the case may be, right? It's going to find a different strategy to kind of do that stuff. So again, the more you take that opportunity for that load to go elsewhere, and you make sure that it's focused in an ankle, a knee, a hip, a groin, whatever the case may be, I think the more success you're going to have early on. So again, like my early ankle stuff, like it's heavy, almost max effort, isometrics, four-way ankle type stuff. To again, like, I know that these guys are going to feel peroneals, I know they're going to feel post-tib, and they're going to feel calf, and they're going to feel anterior tib type stuff. So again, and once you can kind of build that resiliency in that tissue, and again, isometric wise, you'll get some of that pain mitigation, analgesic effect type stuff. You'll typically find that these guys can get up and do a little bit more after you've kind of prepped those tissues and loaded it and kind of change that nervous system response to it being loaded.
Yeah, definitely. How are you doing the four-way ankle isos? Are you using like a wall or a ball, or are you using a band and just kind of doing like a holding isometric against the band, or how do you like to load that kind of pattern?
Sure. So, I mean, early on, I'm doing hand pressure. And again, like, I'm setting my hand on lateral aspect of the foot, anterior aspect of the foot, wherever I'm putting it. And I'm having them pushing me. Because again, I can mitigate the amount of force that I put into them, and then they get the chance to, again, you're giving them control of the session, right? Like, you get to figure out how hard you can push into eversion kind of stuff to load those peroneals. And again, like you said earlier, you get that analgesic effect, you get nervous system calm down. It's like, oh, my ankle's not going to explode pushing this way. I'll push a little harder. Okay, I'll push a little harder. I'll push a little harder, and that kind of stuff. And again, I think that you give them control of the situation, but you're just making sure that the load's going for you, that too, kind of stuff. So that's typically where I'm starting. And then as rehab progresses, I'm taking more towards like end range kind of stuff. So like, I'll do a max effort eversion, holding them in some plantar flexion inversion type stuff. I'm making them activate at length kind of stuff. So normally starting in like a general, whatever you call neutral position, and then gradually working towards end range kind of stuff.
Yeah, that's awesome. I like that progression a lot. And I like how you kind of said, you start from the basics and then progress into just basic multiplanar movement on a high level isometric, because I think it always surprises people with the ISO holds how weak they actually are in certain positions like that, or how difficult it is to generate force in a certain position. Now, we've talked about a few different injuries. We've talked about some great PT considerations for basketball players. From a return to sports side, say someone's been out for a period of time for whatever injury, what's kind of your checklist, or what kind of things do you look for in order to return someone to basketball? What sort of things do you like to look at?
We're spoiled, right? I've got force play data and all that kind of stuff, right? So again, it's making sure that that stuff is trending towards normal, if not better than pre-injury levels. And again, I realize most people have access to that kind of stuff. So I'm trying to think, like, if I'm back in the private sector, how am I doing return to sport? I mean, again, a lot of it, I'm going based off what these patients are telling me, right? I'm listening to their subjective report, like, hey, like, I'm getting back on the court, I'm doing this, that, and the third, but I just don't feel it here. And again, it's reverse engineer whatever movement or skill that is kind of in clinic kind of stuff. Or again, it's conversations with sports or skill coaches or whoever about like, hey, can we get some extra reps of XYZ? In terms of big rocks that I'm looking for, again, I think the majority of PT clinics now have some sort of measurable, right? Whether that's a handheld dynamometry type stuff, if it's your hot testing, whatever the case may be, if it's using your phone for some sort of motion capture type stuff, whatever the case may be, and making sure that stuff's all trending in the right direction. And again, like I was always 95+% limb symmetry for any sort of like true return to competition kind of thing. I think I think that's just a good benchmark. I felt like I had good success with that kind of stuff when I was in private practice. So I mean that was typically what I was doing, whether that was hop testing, strength testing, or even just range of motion type stuff. Like making sure that you're as close to the other side as possible, and making sure that the athlete's participation in sport like drills is progressing the way they want it to, and they're feeling confident, I guess would be the better word for it.
Yeah, yeah. It sounds like a combination of a few objective tests and measures, looking at, single leg strength, maybe like a hamstring quad ratio,
Yep.
and then the hop testing, which is obviously essential for basketball since it's such a explosive plyometric sport in nature.
For sure.
You have to jump in basketball. Like there's no other way around it.
Correct.
And then you compare that with what are you seeing and what is the athlete feeling during all of that, because naturally, they might jump and land and tell you they feel great, but you look at how they landed and you say, that just doesn't look like what I saw before, or
Right.
no one else on the team lands like that. Maybe this, athlete's just an anomaly, or maybe there's something more to the picture here.
Sure.
And going back to what we've talked about a few times already, just like you just mentioned, the importance of listening to the athlete, because if they're doing something for the first time again in a return to sport and they say something doesn't feel right, they're probably right about that most of the time. So
Absolutely.
is there any specific interventions that you like in that phase of the rehab process? Is there anything specific that you're like, hey, this exercise or this combination of exercises really works well with basketball athletes? Or is there like a certain training methodology, like a contrast approach or something like that you like for kind of the later stage return to sport type athlete?
Sure. So I think the biggest thing for us anyway, like where I'm at is making sure that number of accelerations and decelerations are where they were at pre-injury kind of thing. And again, like spoiled could use connects on data and stuff like that to kind of get that stuff. But again, it can even be like if you're going worst case scenario, you have no data kind of stuff. You can go time on feet with like an RPE kind of thing. And again, if you're like, I need you to go like 9 out of 10 effort today for an hour with a typical workout that you normally do with your skills player, and they come back and like, no, that felt pretty good. I just feel a little weak, or I feel deconditioned, or whatever the case may be. I think that's the biggest thing that we're looking at in terms of like training methodology. I mean, I think it's different for different athletes. We spoke to it earlier. Basketball guys aren't known for living in the weight room kind of thing, and these guys, again, they're anomalies in terms of anthropometric type stuff. Like they've got femurs longer than my arm kind of stuff. So again, to sit here and be like, oh, well, they need to squat X body weight, or they need to trap bar deadlift X body weight, or whatever the case may be. while those are good goals, and again, like we want to make these guys just competent movers in general, just to so that we can target load appropriately. Um, I think even the training methodologies, at least in this sector, kind of go back to what these guys feel. Again, like some of our higher level guys, they do a double front racked squat with kettlebells for 5 reps. If it looks good and feels good, then we leave it alone, kind of stuff. You're just checking boxes and make sure these guys have the movement competency to participate in the sport at the level that they want to. And again, these guys know better than I do about what makes them successful, kind of stuff. So it's really letting them play a big role in that sort of thing. Again, like we'll do some velocity based stuff, we'll do banded stuff at the end stage, kind of thing, just to get them into more of like that explosive mindset kind of stuff, get their central nervous system turned on, etc. And then correlating that with our data through force plates and GPS stuff.
Yeah, definitely. I love that, John. Now, I have to admit, out of all the different PTs that I've had on for different discussions on sports, whether it be lacrosse or whatever, not many have brought up the central nervous system type stuff like you have. And I'm really intrigued by that. So when you say central nervous system type stuff for people listening, and they might not understand the role that the nervous system plays in modulating pain, or, really in a way, at least the way I look at it, almost all PT is neuro PT in a sense, because you're rewiring the way the body moves or changing the way the body thinks it's moving or something along those lines. So could you just elaborate a little bit more on kind of the nervous system role in PT and our overall movement approach, I'll say?
Boy, so like neuroanatomy was definitely not my favorite class.
It was not mine either.
my wife was probably the reason I passed that class back in school. So shout out to her. So I'm not going to get into like descending pathway versus ascending path, like any of that kind of stuff.
I wouldn't understand any of it, I'll be honest with you.
For sure. But again, like pain it's a response from the nervous system telling your brain that like something is harmful, kind of thing. So again, like early stage rehab, like stuff hurts, it's inflamed, it's agitated, whatever the case may be. So if you can modulate pain early on, particularly while they're under load and stuff like that, you're going to be a lot more successful. And again, it's recognizing that because of this pain response, the body's typically going to avoid loading whatever tissue it may be, right? So again, like you see a lot of post-op ACL type stuff. It's that constant, like, hingy, don't want to sink in the knee flexion. Knee doesn't want to go forward. They do not want to load their quad. God forbid they had a patellar tendon or a quad tendon graft, kind of thing, right? Like that brain is telling that leg, like, it doesn't feel good. When that knee goes forward, it's harmful, it's dangerous, let's not do it, kind of stuff. So again, it's a progressive loading into some of those ranges or into that movement pattern or whatever the case may be to build confidence, mentally, and again, like you're modulating a true pain response in that area. Not to say that like they don't have pain or whatever the case may be, right? To say it's all coming from their brain and it's not actually there, whatever the case may be. Like it hurts. So again, it's taking them at their word for that and showing them, again, like I've used dynamometry in the past to be like, listen, like previously you were performing the extension at this rate. 5 reps into it, we got to this, right? So again, like it's showing these guys and girls that if we load this stuff, and if you allow yourself to push into some of these painful positions, but in a monitored way, you can get an adaptation that reduces pain and improves function, kind of stuff. So I think that's kind of how I view like the nervous system part of it, kind of thing. And again, especially like when I'm talking like central nervous system stuff, like it's the high rate, high loading kind of thing, like where I don't want these guys thinking about necessarily like, okay, like my knees needs to track over my second toe while I'm performing this kind of stuff. Again, it's like rate coding type of stuff. Like I need these guys to move quick. And again, especially like if it's been a long rehab process, they haven't done that in a while, kind of thing. So it's just making sure these things are tuned up and moving explosively and preparing them for sport. But early on, it's that pain modulation, confidence building type stuff in terms of like what I'm looking at, quote unquote, nervous system wise.
Yeah, that makes a lot of sense, kind of rewiring things. And, I'm glad you brought that up because, like I said before, that's usually not something that gets brought up in the sports PT realm is the role of the nervous system. But,
Yeah.
I do think it plays a very essential role based on the latest pain science research. And,
Mhm.
I'm kind of like it sounds like you, I'm not necessarily the expert on how all that stuff works from a neuroanatomy standpoint. I don't
Yeah,
know, what connects to what. I don't know where it crosses over in the spinal cord, but if you have a general understanding of it, I think it can make a world of difference for you.
absolutely. Absolutely.
So, John, we've kind of discussed a lot of different things here relating to basketball and PT considerations for high level basketball players. Do you have any kind of closing thoughts, closing remarks, or anything that we didn't quite give enough attention that you're thinking about right now?
Not not really. I think we touched on a lot. So again, I certainly appreciate the conversation for sure, and the ability to let me kind of express what kind of circulates through my brain on a daily basis. I mean, I think the biggest takeaway, whether you were private practice, in pro sport, upcoming PT, whatever the case may be, is listening to these athletes, realizing that the higher the level, probably the better the compensator they are. So again, like from a rehab perspective, like you've got to get targeted load through tissues, and it's okay to go back to a basic calf raise, a basic leg extension, a wall sit, whatever the case may be. Like again, we've kind of spoken to it, and I can admit freely that when I was in the private sports world, the glitz and glamour of Instagram posts and reels and getting views and stuff like that from a marketing standpoint, like yeah, like you want some bands hooked up, you want chains here and there, you want these guys doing these crazy movements requiring all sorts of stability and stuff like that. Um, but basics work. That's why they've been around forever. It's why ankle rehab still starts or should start, in my opinion, with four-way ankle stuff, right? As opposed to, okay, let's stand up and put a band into your big toe and balance while this band's pulling you over to your left or whatever the case may be, right? Like I think realizing how effective simple interventions can be, along with just basic feedback from the athlete. I think that's more where my rehab mind has kind of shifted.
John, for people who want to find out more about you, maybe check you out on Instagram, that sort of thing, where can they find you at?
Sure. So I'm just on Instagram, really. So Dr. John Gardner 23. Um, I'm sure we can toss it in the show notes or something like that. I don't think there's a period in it. I
Yeah,
don't do
definitely.
quite. Obviously, we don't do as much of the rehab posting around here as I used to do back in the day, kind of stuff. But I'm hoping to be a little more active there with my thoughts and stuff, especially as we kind of go into the off season and get a little bit of a break, kind of thing. So
Yeah.
hopefully people find some useful previous content on there, and hopefully in the future I've got some better stuff for people.
Yeah, definitely. We'll link to that in the description below here. You mean to tell me you're not on like MySpace or anything, John?
Not a MySpace guy. I've begrudgingly downloaded TikTok. We'll see if that becomes a thing. But as of right now, it's mostly just baby videos. As my wife and I have a 9-week-old, so that's the majority of my TikTok content for them. So if it ever transitions to a PT thing, I'll let everybody know.
You mean to tell me you had time to record a podcast on top of your normal workday and having a newborn?
Well, I've got a superwoman for a wife, so that's the only reason any of this works. So,
John, always a pleasure talking with you. Thank you again for your time.
absolutely. Thank you, man.
Thank you so much for listening to this episode of the Brawn Body Health and Fitness Podcast. If you liked this episode, please make sure to share it with a friend, subscribe so you don't miss any of our upcoming episodes, and leave a review. This way we can spread knowledge and motivation and help reach more people. Thank you again for listening, and I'll see you next time.